I'll be showing two different scenarios in endothelial keratoplasty. One is the vanishing lenticule and another is vanishing DMEK roll, and how we have rescued it. So these both the cases are in post-VR surgery with SFIOL. You know that EK in post-VR surgery is always a challenge, especially in presence of SFIOL. The globes tends to collapse after making the incision, and in DMEK, inferior PI is often difficult. Donor transfer is also a problem, especially in presence of large iris defect, and because the AC behaves differently. And even after injecting the lenticule or roll, the globes tend to collapse, and there is a tendency of creating negative suction within the vitreous cavity, and this results twist during the surgery. So I'll share two cases. One is vanishing DSEK lenticule and rescue, and second was a vanishing DMEK roll and rescue. The first was done by Soham, and it is just, you cannot redo it. It just happened, and rescue is happened as accidentally. So you know that we have described AR-assisted donor lenticule insertion in presence of huge iris defect, especially for aphakia or SEIOL with large iris defect, because it is often challenging. AR tamponade is difficult, and graft might get posteriorly. So we have published this, and this is the original method. You see that in presence of AR, this only the thing is that you have to give a larger main incision, and with a needle 26 with bend nibble, there is no AR escape, and you go right at the back surface of the cornea and then put suture, and this usually do well in our hand, and we have already done more than 50 such cases. But this is the case. I will showing where the problem happened. There is a SFIOL, and you see the iris defect is there, and the surgeon was Soham, and as usual the AR injection is given, and in this case always it is preferable to do the thing, and surprisingly it opens in right direction. So you probably can never do it again. It is just accidental rescue of this thing, and then usually you put sutures and give sufficient AR tamponade, and this patient, you see that after all this manipulation, this patient is doing good, 624 vision with 1300 cell count and all. This is the vanishing, this is my old video, vanishing DMEK roll and rescue. This is again a case of this thing post VR with SFIOL, and you see that I didn't know, history was got from the patient, that PR surgery, old patient. I did during PI, I realized that there is actually IOP is so low. So while going in, I was just tapping over the, that time I didn't have much experience actually. You see that I was tapping and it was going inside the pupil. I didn't realize that it goes inside the pupil. So it is definitely behind the iris. I try to locate it, and then I try to feel it with a Sinski, whether it is there or not. Then I tried with McPherson. First time it was miss. Second time I could catch it. The DMEK roll is there, so I take it forward into the anterior chamber and then take the whole graft into the anterior chamber. This time I was very careful and I was slow in tapping and sweeping movement, and then with little tap from the periphery I could open the graft and you see that S mark is visible now. Only the centering is to do. S is visible in lower part towards 6 o'clock position, and then I put here. So this is the end of surgery, and this patient did well. After this is post-op day 4, 660 vision, and this is post-op 1 month with 612 vision with a good cell count. So be careful while performing EK in post-VR surgery. That is the take-home message. Thank you very much for your patience, Eric. If you have any question, I can take questions.
What about having the post-VR cases, because you don't have a support from behind? Wanted to have, like Samresh showed us, pars plana infusion, which will keep the pressure up always.
We have not done it, but one thing we used to follow here, Soham, is that we always put a suture in the lenticle, so that if it falls, that suture you can take it out, even in case of aphakia or in presence or absence of oil. So that was not done in this case, but we never had that increasing that. But usually those fluid use tends to come out because your wound is very large here, so possibly it is, but when you tap, the fluids tends to come out. Nowadays, what we prefer that in DMEK especially, we take older patient donor, older donor graft, so half open, it is always half open, so you need not to tap it more. So once you go in and you see the orientation, you can sweep it on lateral movement, and so you do not have to tap again. And I have seen the video that donor lenticle, DMEK roll goes inside. In one of my case, the donor lenticle goes inside the vitreous. I didn't disturb it. I put a dissect lenticle in that case, and I checked with the VR colleague, where is that DMEK roll? It was stuck to one side of the retina, so near the pars plana region. So it was not causing any hampering, so I said, no, don't touch it. Let it be like that.